Hi, this is Dr. Mario Del Cid at the Retina Group of Florida. Today we're going to discuss retinal OCT. OCT, or optical coherence tomography, is a diagnostic test that allows for imaging of various ocular structures. It can be used to look at anterior segment structures, optic nerve, and of course in our setting we're focused on the retina and the macula. It essentially gives you an optical biopsy of the retina, and it gives us a lot of information, including both qualitative and quantitative. There's a lot of pros to OCT. Major ones are that it's non-contact, it's non-invasive, it's painless, reproducible, fast, reliable, and sensitive. In this slide it says 5 to 7 microns. It's actually more sensitive now with newer machines. Disadvantages are few, but you do need a relatively clear media, especially if you're going to be analyzing retinal structures. And at this point, the peripheral retina is difficult to image, although this is being worked on and hopefully will be worked out in the coming years. From a historical perspective, things have progressed rather rapidly over the past few decades. Initially, work by specialists at MIT and Mass Eye and Ear really advanced OCT to its first commercially available OCT released by Zeiss in the mid-1990s. Of course, now there's lots of different options available with a very advanced software, and the future looks bright. How does it work? So OCT is an optical ultrasound. It uses optics, which means it uses a light source. It's a near-infrared light source. It uses coherence, which is a particular property of light waves, and it's tomography. In other words, it's imaging by sectioning. This is a schematic of how OCT works. It's overly simplified, and for our purposes today, we're going to go through this rather quickly. So here on the left of the picture, we have a light source. This light source is being reflected onto this reference mirror, onto this splitting mirror, excuse me. The splitting mirror then splits this light source into two beams. You see one beam is working its way upwards, that's the blue beam, and the other beam, it's working its way to the right of the image, and that's the red beam. These beams are then reflected. The top beam is being reflected on a reference mirror, and the right beam is being reflected on the retina. Of course, if this was anterior segment OCT, it'd be reflected on some anterior segment structure, or perhaps the optic nerve if we were imaging that. This light beam is then reflected back again towards that splitting mirror. As it reflects on that splitting mirror, it then works its way down. Now we have both the blue reflected wave from that reference mirror and the red reflected wave from the retina, and they're both working their way down towards that light detector. As they work their way down, the beams are now out of phase with each other. And this is what we mean by coherence, is this difference in phase of the light waves is what's being processed by the light detector. The processing initially gives an A-scan interpretation, which is then further processed to give a B-scan interpretation. That's what we see on the computer screen. There's this concept of enhanced depth imaging, or EDI, which is utilized to analyze choroidal anatomy. What's done in this situation is a zero delay line, which is a line of peak sensitivities, moves closer to the RPE instead of that vitreoretinal interface, and it gives you more choroidal information. It can be thicker in cases of central serous retinopathy or posterior uveitis. It can be thinner in inherited retinal conditions, in macular degeneration, myopia, age, and of course EDI can be very helpful in imaging choroidal tumors. A normal choroid in the macular area should be just about as thick as the retina. See, this is normal choroid. This is a slide, an older slide. It says this is the future, and the future is already here. We already have OCTA. We already have intraoperative OCT. We already have en-face imaging. So the future progresses rapidly, and it looks very bright. This is a histological section of the retina. I put this here because, as we said before, the OCT is essentially an optical biopsy of the retina, and really we're seeing layers of the retina. It's almost a histological section of the retina. It's quite amazing. These are all the layers that we see on OCT, and obviously we're not going to go through each and every one of these layers, but we're going to highlight just a few of them. The first is the nerve fiber layer. That's the innermost hyperreflective layer. This represents axonal segments as they work their way towards the optic nerve. The outer plexiform layer, we discussed in our common retinal conditions, cystoid macular edema. We said that it tends to be fluid accumulation within the outer plexiform layer, so this is where you would see cystic spaces in a patient with CME. The external limiting membrane, I highlight this just because it has important prognostic indications. The ellipsoid zone, which essentially represents photoreceptors. The interdigitating zone, this is how the photoreceptors interdigitate or relate to the RPE. This hyperreflective thick band here is the RPE, or Brooks complex. So when we review OCT, I like to be systematic about it. I like to review it by layers, and I usually like to go from a top-down approach. So first is the vitreous. You see this vitreous looks rather clear. You might get a few little opacities floating around in the mid-vitreous there, but otherwise it's an optically clear view. You see the image acquisition was perfect because we have a very clear view to the retina. In cases of vitreous hemorrhage or, say, asteroid hyalosis, these are conditions where you can get some opacification of the vitreous. You may see things floating around in the vitreous cavity. I like to look at the foveal anatomy. Here you see a nice normal foveal contour. It looks smooth. You see this very regular appearing foveal depression. Next, I like to look at the ellipsoid zone. All right, we said that ellipsoid zone represents photoreceptors. Want to make sure that's intact. The interdigitating zone, which is just outside of that ellipsoid zone. Again, that's a layer of retina relating to or interdigitating with the RPE. And finally, that RPE layer. So those are the three hyperreflective bands that you see on the outer retina, which is the sort of the deeper layers of the retina, at least when you're looking at this image. And finally, look at the choroid. This has a nice normal choroid. Several sources of error. These are things that photographers are always on the lookout for. The first and most obvious is making sure you have the correct patient and that the age is correct on the patient. If you have the wrong age, some of the normative data may be altered if the wrong age is placed. Scan placement is critical. If the scan is not centered, it can give you a bad reading or bad measurements. And this is here on the right is a great example of poor centration. The top image is a poorly centered image. And what happens is when you look at the numbers, the decentered scan gives you a falsely elevated foveal thickness, 293 microns. When you center this correctly, we actually have a 254 micron central foveal thickness. So that's a 40 micron change, which in certain conditions could be very significant. So make sure that the image is well centered. Poor signal strength can also be an image acquisition issue. These can happen in situations where there's dry eye, there's small pupil, media opacity such as cataract or vitreous hemorrhage. And then there's various sources of artifacts which we're going to look at here. First of all, boundaries, image boundaries or segmentation lines can be thrown off by various conditions. In most machines, not all, but in most machines, the inner boundary uses the internal limiting membrane. And the outer boundary, again, depending on machine, can use the ellipsoid layer, or RPE, Brooks complex, and others. You see, in this situation, we have a patient who has very severe cystoid macular edema. Because the edema is so pronounced, the software is having a hard time figuring out where to put these inner and outer boundaries. So it correctly identifies that inner boundary, but this outer boundary, it just kind of randomly placed it in the middle of the retina. So we have incorrect boundaries, and as such, there's lots of artifact on the thickness map. Normal macular thickness, it can vary depending on machines, but in most circumstances, you're looking at about 250 microns. Now, this is one of my favorite aspects of OCT. This is called the change analysis map. So what you see on the top image of this OCT is there's a large area of macular edema. The retina is swollen, it's red, it's white. That's all swelling, and the patient was treated. This was a patient that received steroid injection for cystoid macular edema, and you see the swelling has subsided, and you get a nice correction, which is highlighted there on the change analysis map. Okay, let's look at some cases. So we said fluid, cystoid macular edema. This is a patient who has lots of cystic spaces here in that outer plexiform layer, much of it within the fovea. The OCT clearly highlights that thickening, the swelling, the cystic spaces, and the angiogram also shows a petaloid type leakage, which is very characteristic of a patient with pseudophakic macular edema. So you see this large cystic space, fluid in the outer plexiform layer, and petaloid leakage. This is pseudophakic cystoid macular edema. OCT can be very useful in imaging patients with retinal detachment. Here we have a large pocket of subretinal fluid. Now this is one situation where you see some artifact. You see here the retina has been inverted because it's essentially out of the image, and so the OCT inverts it. And here we have a fundus photo of clearly a retinal detachment that does indeed involve the fovea. Here the OCT clearly shows a large pocket of subretinal fluid. This pocket here underneath the retina is what's called a pigment epithelial detachment, or serous PED. See on the fundus photo, there's a pocket of subretinal fluid here, and your fluorescein angiogram shows your characteristic smokestack appearance of a patient with central serous choroidopathy. Here we have a red-free image which shows clearly an area of macular atrophy. There's pigment loss here. And on the OCT, you see the image looks much different than your typical OCT. Has almost an egg-shape appearance. This is called a staphyloma. You see the choroid is paper thin. And you see these almost cystic appearing spaces. However, you notice they're not in the outer plexiform layer. This is something called a schisis. It's a splitting of the retinal layers in a patient with high myopia. This is known as myopic maculoschisis. Multiple different images displaying various aspects of wet macular degeneration. Here's pockets of subretinal fluid. These are serous pigment epithelial detachments. Within the retina, we see exudates. That's a sign of chronic leakage. Within the retina, we're talking about in the outer plexiform layer here, you see a cystic space of cystoid macular edema. Similarly, in the bottom image, you see some cystic spaces as well. In this case, you also see a hyperreflective band underneath the retina, just on the surface of the RPE, which is a disc-formed scar in patients with neovascular or wet AMD. Various vitreoretinal interface disorders can be also imaged on OCT, and this can be actually quite useful. So here, this is actually a normal appearing OCT, and what you see is the posterior hyaloid, the back surface of the vitreous, is still attached to the retina. So this is a posterior hyaloid face, or the cortical vitreous. So this patient does not have a posterior vitreous detachment. Here, however, you see floating around here in the mid-vitreous, you see this hyperreflective band. That's actually the posterior hyaloid face there. It's lifted. It's detached from the retina. This is a posterior vitreous detachment. Here you see a hyperreflective band on the surface of the retina. That's a mild epiretinal membrane. And as we go along, they get more pronounced. You notice that the foveal contour, although a little irregular, is still predominantly intact. Here with a more moderate, more pronounced epiretinal membrane with some vitreous attraction, you see that the foveal contour has been made more irregular. And here you have a more dense epiretinal membrane with cystic spaces and a lamellar macular hole. One could also image vitreomacular adhesion. This is traction. The vitreous is attached to the foveal area. It's pulling somewhat, and you see the foveal contour is no longer regular. It doesn't have that smooth, depressed appearance. Rather, it looks somewhat elevated. That's due to traction. Here we have more vitreous traction starting to cause a full-thickness macular hole. And in the bottom image, we see the full-thickness macular hole has been complete. This is a stage 4 hole with an operculum and some cystoid macular edema. This is an interesting case. On first glance, it looks pretty normal. Foveal contour looks normal. However, when you look carefully at the image, there are some irregularities. First, on the red-free image, you see a dark spot here. There's a foveal irregularity. And here, this is most critical. We mentioned those 3 layers, the ellipsoid layer, the interdigitating zone, and the RPE layer. And here you see damage to 2 of these layers. There's a ellipsoid layer and the interdigitating zone are discontinuous. This is actually a case of solar retinopathy. Happened shortly after a solar eclipse. So using OCT as an adjunct to history and exam can be quite useful in addition to other testing. Here we have a red-free image which shows macular parafoveal irregularities in the RPE. You see it's highlighted on the color image as well as the fluorescein angiogram. And the OCT clearly shows that the RPE, the retinal pigment epithelium, along with those other layers, right, the interdigitating zone as well as the ellipsoid layer, are discontinuous or irregular within the perifoveal area. So this is perifoveal RPE atrophy, loss of those critical hyperreflective bands. Putting this all together, this looks like a bullseye, doesn't it? And it sure is. It's bullseye maculopathy, and this is due to chloroquine or plaquenil toxicity. Again, multimodal imaging. A color photograph showing hemorrhage and a linear break in the RPE. The OCT shows that hemorrhage and then the discontinuity or break in the RPE and the choroid. This is a case of traumatic choroidal rupture. This is a paintball injury. Finally, OCT here shows a large pocket of subretinal fluid. You see, this is the most interesting aspect of this OCT, is if you look at where the fluid is coming from, it seems to be possibly coming from this optic nerve. It's continuous with the disc. The red free image shows that pocket of subretinal fluid. And here, if you carefully inspect this color fundus photo, you would notice that there is indeed an optic nerve pit. So in conclusion, OCT is a very useful diagnostic tool. We want to look for quality scans. Remember the multiple sources of artifact. Recall retinal anatomy. Think top down. Be systematic about your interpretation. Remember the layers. Pattern recognition is useful. Once you see these over and over again, you can almost pick up what's going on from the OCT rather quickly. And thankfully, there's a bright future ahead for OCT. Thanks so much.